everybody hear me? Yeah. Okay, not too much. Okay, great. All right, what I'd like to do this afternoon then is go over some background, just to make sure that we're all on the same page, because to make this topic interesting, you have to understand some of the basic stuff about what happens as people get older and about Alzheimer's disease and vascular disease. So some of that may be familiar to you, or some of it may not. As I say, it's got to kind of have to go through that.
Thank you.
And then I will talk about some of the relationships between vascular health and memory and Alzheimer's disease. I'm going to try to leave a lot of time for questions. I see as one of my main jobs to try to keep you awake after lunch, so in that interest, I will try not to talk too much, and leave time for you to ask your questions. Okay, let's start. I want you to think about this question: what is normal? It's a question you can spend a lot of time thinking about. But what I want you to think about is just what is your image? If you were to draw a line that would describe what happens to mental ability as people get older, what do you think it looks like? What normally happens to adults as they get older? Here's some data on this, and let me explain. I'll walk you through this, what you're looking at. This is a study we did a few years ago with colleagues at Rush University. We've done a very interesting thing. They took about 1,000 people out of the community, just regular people, and followed them for many, many years, measuring their memory and mental abilities very carefully over a long time, following them until the time they died. And so we took this data and we looked at it with some methods that let us sort of describe what happens to people. And one of the first things that comes out is that it's the question of what happens to older adults, what happens to memory and so forth with age, is actually a little bit of a trick question, because it's not just one thing. There's a lot of variability. It's not just one thing that happens, but you can kind of describe it in, there's kind of three groups if you follow people along. So, what you're looking at here are three different groups of people. So these are people who sort of come together, changed in the same way. And black is one group, the green is one, and then the purple is another. And what you're looking at is how people change over 5 or 10 years, starting at different ages. And so you can really kind of right away see that it's not just one thing. In black here, you have a lot of people, and okay, so this is memory over here, and the higher you are, the better memory. And what you see is that for a lot of people, they're changing very little. From their 60s to their 90s, you see very little change. A little bit, but very little. And then you have this group where you see some change. They're definitely changing faster. And then you see these people, and they're changing really fast. So it's fair to say that some people change a little, some change medium amount, some change a lot. How many people do you think it broke down in these groups? So another thing we did was to look at how long it would take to detect a change in these different groups. So remember I said there was a slow changing group. This slow changing group, things are changing slow, because it would really take you about 17 years on the average to notice that their mental abilities had changed. Very slow change. Okay? In this medium group, it's much faster. You'd notice a change after 4 years. And in the really rapid group, they're just sort of falling off the cliff. This is less than a year. So again, just think to yourself, what percent of adults fall into each group? And I don't know if that's what you expected or not, but I think the good news in this is 70% of the people were in this very slow change group. Then, about a quarter were in the medium change, and then there's a small group where things really are going wrong. points is that a lot of change in cognitive function is not a normal part of aging. Rapid change, major change in cognitive function is disease. So it's always driven by disease. And the part that's driven by disease is complicated. And this, so one of the things I want to show you here is that it's not all explained by disease in a simple way. I'll explain these things in a little bit more detail in a minute, but basically each of these graphs shows one of the markers of Alzheimer's disease when you look in the brain. And these are the three groups. These are the slow changing, these are the medium, and these are the fast. And the point is, you don't see a lot of difference. If you don't see a lot of difference, it's because there isn't a lot of difference. There's a lot of overlap in this. And this can explain some of it, but it doesn't explain all of it. So, normal is not fast, disease is fast, and disease is not all Alzheimer's disease. Okay? So I think that's, right, okay, so that's kind of what I said. All right, when we talk about what are the diseases that really affect mental function in old age, there's a lot of them, but the two big ones, the ones that drive almost all of the change, are Alzheimer's disease and cerebrovascular disease. So what do I mean by cerebrovascular disease? We talk about stroke, but I'm not just talking about the major kind of stroke where somebody all of a sudden loses speech or becomes paralyzed, and then just can't move on one side. There's a whole range, and I'll talk about that more in a minute. But these two things are what drive cognitive change. So let me go through a little bit of background on both of these, okay? Because one of the things that I'm going to want to tell you is these are the two major things, and they actually come together in interesting ways, and it's because they come together that there's so much of the connection that you hear about these days between heart health and brain health, okay? So, some basic things about Alzheimer's disease. As we understand it now, Alzheimer's disease begins when normal proteins that we all need, break down into very small pieces. And these small pieces seem to set off a chain of events that years later result in the cells of the brain dying off. And when that happens, the brain no longer functions normally. And when you look at the brain after a person dies with Alzheimer's disease, there's two pathologic changes that you see that Alzheimer described way back in 1907 when he published his first case, and that still define the disease today. So one is amyloid plaques. And these are microscopic pictures, and they're just these kind of blobs of these abnormal protein fragments. And then you get another, as you can see, it just looks different, and they're neurofibrillary tangles. They're also a set of proteins, a different protein called tau. So amyloid and tau are these two abnormally structured proteins that you see in the brain in Alzheimer's disease. So this is a process that develops over a lot of years, but there is a lot of evidence to suggest that it begins with this amyloid, okay? And so very briefly, what happens is they say there's this normal protein that, this is the cell body, that it attaches onto the cell body, and it gets cut in a couple of places by enzymes in the brain, and you get these little pieces of what they call beta amyloid floating around. And these eventually come together and they form those plaques that I just showed you the picture of. Okay. Turns out that these plaques all by themselves are not particularly bad for you, but they do seem to start a chain of events that is very bad for you. But understanding what influences the production of amyloid and how much of it is around turns out to be very important, and I'll mention that at various points in the talk today. One of the really interesting and important research advances over the last decade is that we can now see these plaques. These are microscopic, but now there are methods that you can use brain imaging to actually see these in living people. And so these are images. You use PET scans. There's a particular tracer that basically locks onto these things, and then you can use this to take a picture of essentially how much of this amyloid plaque is in the brain. And when people have significant amounts of this amyloid, it's really not hard to see on these images. And so this is an example of it. Here's the back of the brain, the front. This is as if you were cutting across the brain. And the red, the warm colors show where there's amyloid, and the warmer. So red is a lot, and the yellow is medium, and you can see this person has a lot of amyloid. It's real obvious. And then these other people have sort of intermediate ones. But this has been a tremendous thing that's helped us understand a lot more about amyloid. And one of the points, as I say, this stuff is not so bad for you all by yourself, but it leads to a process that results in brain atrophy. By brain atrophy, I mean shrinkage, and that doesn't sound good, and it's not good, because what it reflects is that the neurons in the brain are dying and actually being lost. And over the course of Alzheimer's disease, it's not unusual for a person to lose a third of the brain weight. It's a tremendous loss of tissue, and you can see that. I don't think I have a pointer, but if you see the top area, these are MRI scans, so it's taken during life, and the dark parts are the normal protective fluid of the brain, and the light parts are the tissue. And if you compare the picture on top with the picture on the bottom, you can just see there's a lot more brain in the person on the bottom. And that's the kind of really devastating atrophy that Alzheimer's disease causes. I think one more thing I should say about Alzheimer's disease. It's very important, and this has come in part from these brain scans that we do now. Alzheimer's disease is something that develops over a long period of time, like decades. From the time that the amyloid really begins to accumulate in the brain to the time that symptoms appear is something on the order of 12 to 15 years, and before the person gets demented, it's probably in the 12 to 20 years. It's a long disease process. So the good part of that is it suggests there's a lot of room in which you can intervene. You can do something while this disease is developing. Okay, let's talk about stroke for a minute, just so everybody is on the same page. Stroke, in contrast, is very sudden brain damage. And stroke is when the blood supply to the brain is cut off. When that happens, you've got very little time before the neurons die. It's a matter of minutes, a few minutes. So if the blood supply is shut off, the downstream, the areas that the vessel supplied die off. And that's the major thing you need to know about stroke. As I say, most of you are familiar with large strokes. Really want to emphasize these large strokes that you see that leave a person paralyzed or unable to speak are just the tip of the iceberg. These kinds of things really happen in a wide spectrum. So one way of thinking about that is if a big vessel is shut off, you get big areas of damage. That's supplying a lot of brain. But there are small vessels and there's even microscopic vessels. And they can get closed off as well. And just like you'd expect, it's a small vessel, it's a small stroke. And in fact, somewhere around 20-25% of the people who are over 65 have had what you call small strokes, but they don't even know it. The doctor doesn't know it unless they've done an MRI, where the MRIs are very sensitive for seeing these things, and you can detect them. But they don't have any major outward symptoms. And so, as I say, 25% of people walking around that had small strokes don't even know it. And then there are changes in the white matter, which I'll show you in a minute. These are the connections between different areas of the brain. They get damaged by the same sort of process where the blood supply is shut off. And ultimately, again, the nerve cells of the brain are lost and the brain shrinks. So stroke is not just the stroke that puts you in a wheelchair. It's a whole range of things that happen to the brain. So I said white matter. When I'm talking about white matter, they're really loud. Maybe we should do something competing. I didn't really think of that exercise like that, but I don't know if we got an idea. Yeah, we can answer back. So white matter, up here we've got an MRI, again, the back of the brain at the bottom and the top at the top, it's cut crosswise. And deep within the brain, there are these white matter connections. And when we do MRI scans in a certain way, you can see when the white matter is damaged, it lights up. And you see these white areas, these very bright areas on the image, and it tells us that something has gone wrong. I want you to look at this picture because it tells you why this is important. So you see the little white spot up there, that's coming from an area like this. It's been damaged. Why is it important? Because here in this image, what they've done is to outline in blue the connections that this one particular tract of white matter that makes. And the point is that this tract, which runs from the back of the brain up to the front, reaches out to all over the brain and is connecting many, many, many different areas, many, many different neurons. So you can think of this as the wiring of the brain in a way, and you can begin to see that if the wiring's damaged, even if the cells out here are okay, you've got a problem. And so that's one of the ways that cerebrovascular disease begins to affect thinking. And it's one of the reasons that we don't want these things to occur. They also are very common as people get older. I mean, you know, probably if you did an MRI of my brain, I have some of it. You know, the older you get, the more likely it is that you have some, and the older, the more there is. But there's really a range. There's a huge range of how much of this we see in older people. Okay. All right, so cerebrovascular disease, Alzheimer's disease, how do they come together? What I'm going to show you now is some other data that came from the group at Rush. This same kind of thing. They followed people through the community, and now these people have died, and they're looking in the brain. And the question they asked is, okay, what do we see in the brain of people who died with dementia? So by that I mean people who had serious memory loss that interfered with daily function. So these are people disabled by memory loss versus people who are living independently and basically okay. So let's just compare what do their brains look like. And they have different kinds of abnormal findings. So here we have, so these are people who are demented, and this bar is Alzheimer's disease. So these are the plaques and tangles that I was showing you earlier. These are small strokes, okay? So a couple things would stand out when you just look at this. First of all, these things are fairly common. That's maybe not a surprise, except that, look, this is a percentage table, and it's not even half the people have those things. So it's not explaining the whole reason that they're demented, but maybe that's not too surprising. But this gets interesting when you look at this in comparison to the normal people. So this is the amount of Alzheimer's pathology, the plaques and tangles in people who were normal. Almost no difference. Almost no difference. And what about brain infarcts? the strokes? Well, in this group, these people actually had, the normal people actually had more. I don't think that means it's good for you, but maybe, you can have some of it and your brain stands up to it. But over here is where you see a big difference. And what this bar is what they call mixed pathology. So these people had multiple things wrong with their brain. And what they usually had wrong was a combination of strokes and Alzheimer's disease. And you can see, again, big difference. Relatively uncommon in people who were thinking normally, people who really had serious memory loss, very common. And I think this is a really, really important thing to understand. Alzheimer's disease doesn't usually happen in a brain that is otherwise perfectly healthy. Alzheimer's disease happens to old people. Old brains are affected by a lot of things, and cerebrovascular disease is the most common thing that affects the older brain. And there's something about the combination of these two things that's really important. And it says also that if you want to avoid dementia, if you want to reduce how much dementia we see, maybe it's over here that you should be working. That if you can reduce the multiple things that go wrong in the brain, you can have an impact. So let's focus on the vascular part more for a minute here. I said Alzheimer's disease develops over a lifetime. Vascular disease does too. And what this is showing, this is a study done by a woman at Northern California Kaiser. And what this shows is that the major things that are risk factors for stroke and heart disease are also risk factors for dementia. So here we have high blood pressure. If there was no effect, the line would only be this tall. You can see there's a little bit of an effect. Diabetes, elevated risk, high cholesterol, more risk, smoking risk as well. The interesting thing about these were measured in midlife. These are vascular risk when people are 40 or 50 years old, and the dementia obviously occurs when people are 70 or 80 years old. These things happened a long time ago. They have an effect way downstream. And the more you have of them, the worse it is for you. Not surprising. You don't need to pay attention to the color of the bars. They're both essentially the same thing. And this just shows that with respect to Alzheimer's disease, the more of these vascular risk factors you have, the higher your odds of getting Alzheimer's disease. So no risk factors here. 1, 2 risk factors, 3 risk factors. And the risk factors I'm talking about, again, are things like high blood pressure, diabetes, smoking. Those are the major ones that they're looking at. So, and again, this is not a risk of stroke. This is a risk of Alzheimer's disease, clinically diagnosed Alzheimer's disease. And these things were also measured during middle life. Yeah?
So are there any studies that also measure toxin exposure? For example, people who have jobs related to high toxins, or military people who have been exposed to a lot of toxins, besides these other factors. My dad doesn't have those other factors, but he has severe toxins.
Yeah, so the question was about toxins. So toxins is really a different topic that I'm not going to get in much today. Partly because the picture is just right. Partly because the picture is just not very clear. The vascular effects, I think, are very powerful. The environmental exposure stuff is very complex and not very clear at this point. That's a short answer. So,
well, alcohol is a risk factor.
I'm going to come back to alcohol. I'm going to come back to alcohol. Okay. So higher vascular risk, higher risk of Alzheimer's. And when you look at specific things, the pattern that I want you to notice here is that these are things that you have heard a lot about, probably with respect to the risk of heart disease and stroke. You hear about this all the time. But here, the bad outcome is not heart disease, the bad outcome is dementia. And so this is just fat intake, and again, this is a Finnish study. They're following people over time, and they're just studying the amount of fat that they reported eating in their diet in relation to dementia. Again, low, medium, high, low, medium, high. The more you eat, the higher the fat percentage, the worse your risk of Alzheimer's disease and vascular dementia. What about exercise? Same pattern. Here is no exercise, and you can see the risk is quite a bit. Exercising some actually significantly lowered a person's risk of dementia. I'm going to talk more about exercise, but one of the things I want you to notice here, this is kind of an effect of none versus any. So you don't have to be, these are not people who are running every day. These are just serious couch potatoes. These people really don't move. And everybody else does better. So it's just, but you do see this really pretty strong effect in relation to the risk of dementia.
A question about the fats. So did they distinguish between healthy fats and
No, I will talk more about fats, and that turns out to be actually very important. Yeah. And then diabetes, I'll just say, just in general terms, diabetes is very interesting. Behaves a little bit differently than some of the other risks in this way. So diabetes raises the risk of heart disease and stroke. That's very clear. And obviously, as I just showed you, stroke in combination with Alzheimer's is a very bad thing. There's good evidence that people who have diabetes sort of get worse faster when they have Alzheimer's disease. That's bad. And one thing I didn't say, there's a whole other pathway, just apart from Alzheimer's disease, people who go into diabetic coma, where the blood sugars get extremely low, that's a very dangerous situation, and it directly and very rapidly attacks the brain, and particularly attacks the areas that are important for memory. So that's another thing. But, so diabetes has a range of effects in terms of Alzheimer's disease and stroke. Curiously, when you actually look at the number of plaques and tangles in people who have died with diabetes and Alzheimer's disease, their levels of the plaques and tangles are lower than other people with Alzheimer's disease. So that's not what you'd necessarily predict. But what this says to me, again, is probably the combination of diseases that is affecting the brain. And that diabetes leads to vascular problems, and they combine with Alzheimer's disease to create dementia. So, okay. Again, sort of emphasizing this theme, but I think it's interesting to think about how these things develop over life. Yeah.
the diabetic coma?
Yeah.
Basically the same thing as the hypoglycemia?
Well, it's very bad hypoglycemia. Hypoglycemia is the person is awake and they don't feel well, but they're still getting enough sugar. In the real diabetic crisis, the person's probably unconscious, and it's an emergency.
But if you don't maintain as far as the hypoglycemic, it keeps going at a low.
I don't think that, I don't know that there's any evidence that hypoglycemia itself creates any risks.
So, a question about the diabetic coma then. So, if you go into the diabetic coma, your blood sugar goes off the charts much.
Yeah, that's a different thing. High blood sugar is also bad for you, but if you're going to choose, go high.
Well,
I mean, really, I'm not serious. Not continuously, but people whose brain tolerates, way too high glucose much better than way too low. So there's a rule.
Can you define what too low and too high are? Too low is like 70, and too high is like 180, or what?
I'm going to put those questions on hold, okay? Because I want to go through some of this other stuff. My slides seem to have maybe advanced for me. Just telling me how to move faster. But let me back up through this a bit. So here's what I want to show you, is how these disorders develop over the lifetime. And what I'm going to show you is lines that show you, what I've got over here is the percent of people that these things affect. And then along here is age. So like that line that just hopefully appeared, this is multiple vascular risk factors. And these levels are really high in this country now. These are multiple major risk factors. So these are smoking, high blood pressure, diabetes, high cholesterol. And you can see even at a fairly young age, there's a pretty good chunk of our population has multiple risk, and it just goes up over the lifespan. And then what this line is actual vascular disease. So this is serious atherosclerosis that you see in the blood vessels. So now you're seeing not just risk, but you're seeing damage to the vessels. A few years later, you begin to see these changes in the white matter, small infarcts in the brain, small strokes that you can see on the MRI. But these are probably not clinical events. And then a few years later, you actually see major strokes beginning to appear. So these things sort of play out over the lifespan. People begin to get demented much later in life. And you can see that curve really kind of takes off from around age 60 and it goes up from there. And that really follows, by a number of years, amyloid deposition. So those brain scans that I showed you with the amyloid, you can begin to get measurable differences 10, 15 years before the dementia takes off. So again, these are lifetime kinds of things, and when Alzheimer's disease happens, it happens very, very often in a backdrop where the brain has been exposed to things like diabetes and high blood pressure for a long period of time. Now, okay, so what I've talked about so far is essentially you've got two disease processes, and you can kind of understand for sure that two diseases are worse than one. It actually may be more complicated than that. The things that are risk factors for heart disease and stroke may actually directly accelerate Alzheimer's disease. They may actually accelerate the development of this amyloid. So this is some work that we've done, published last year, and what we looked at was we measured how much risk for heart disease people had. We used a scale that's commonly used to predict a person's 10-year risk of heart disease. And that's what's over here. So here are people with low risk, here are people with high risk. And then we looked at that in relation to amyloid measured in the brain with these brain scans. And so here's low and here's high, and you can see that it goes up. It goes up. And so this is suggesting that there may be a sort of fundamental link between these processes, and that the things that lead to stroke can actually accelerate the process of Alzheimer's disease, making this very complicated. Okay, let's talk about what you can do. These are probably not popular suggestions. Let me try to make them more popular. But I really do mean these quite seriously. I mean, people are interested in supplements, people are interested in various medications, people are interested in what they can do to reduce the risk of Alzheimer's disease. And I really think if the two most potent things you can do are these two things. Let me show you some of the evidence about this, and it's really pretty interesting. So, as I said, if I had a miracle drug, if I told you that I could sell you something that would treat diabetes and high blood pressure, like reverse diabetes and drop your blood pressure, it would reduce the plaques and tangles of Alzheimer's disease, it would actually prevent them from developing. It would actually increase the volume of your brain, and it would improve the functioning of the brain. It'd probably pay me a lot, right? You can't do that. But the miracle drug is exercise does all of these things. There's evidence that exercise does all of these things. Yeah, we'll get to that. How much is, yes, right. We'll get free. Yeah. So you know, you've all heard about it, and it's obvious, I think, with diabetes and high blood pressure. But this is very interesting. So Carl Kottman is down at UC Irvine. He's done some very interesting work. One of the other major research advances in Alzheimer's disease in the last 20 years is we figured out how to give mice Alzheimer's disease. This was not an easy thing to do. Mice don't develop Alzheimer's disease. You have to, so it's genetically modified mice, and you have to fairly substantially modify them to give them Alzheimer's disease. But once you do that, then you can study these processes in mice. And Carl's done some very interesting work where you take these mice, and then he just compared mice that are just let to sit around in their cages versus mice that he makes run on a little exercise wheel, and then looks in the brain. And the mice that run have much lower levels of the Alzheimer's plaques in their brain. It's really very impressive. What about these other things that it improves, builds brain, and so that's in mice. Okay, we don't know that in humans now, but some of these other things we do know in humans. So this I showed you already, so I'm going to skip it. This just shows that exercising reduces the risk. But this is, I'm just going to focus on one article really with respect to exercise. Very interesting article, very important, I think. So this came out in a very good scientific journal a couple of years ago by Alzheimer and some people at the University of Illinois.
Which journal?
PNAS, Proceedings of the National Academy of Science. And so let me tell you, so here's what he did. He took 120 people over the age of 55. They were in their sort of upper 60s on average. And he took 60 of them and he just randomly assigned them to two groups, 60 and 60. One group he assigned to an exercise group, the other he assigned to a stretching group. So they both got attention, they both did some physical stuff, but the one group was just stretching and the other one was exercising. And then he followed these people. He had them do this for a year and then looked at, and then he did MRI scans to measure their brains when they started, did memory testing, and then he did this again at the end. And the results were really, really pretty cool. So just look at the top here. My arms aren't that long, but where it says hippocampus. So this column here is the left hippocampus and the right. It doesn't matter which one you look at. Let's just look at the left. But the red line is the size of the hippocampus for the people in the stretching group. And you can see it's going the wrong direction. That's the way it usually goes as you get older, I'm sorry to say, but you can see it's getting smaller. The blue line is the exercise group, actually getting bigger. And so you might wonder what's going on, and that's not entirely explained, but the other really cool thing is that when you looked at memory function, you saw the same kind of thing. The people in the exercise group actually were remembering better at the end of the year than they were when they started off. They were doing better on memory tests. So, and I don't know if I said it, but the reason he looked at the hippocampus is because the hippocampus is the most important structure in memory. It's the single most important structure in memory. So you need it to form new memories. So exercise made the hippocampus get larger, this critical brain region, and improved memory. So now your question, how much exercise? This was the thing. So here's what he had them do. They were walking. And how much were they walking? The first week, 3 times a week, they had to walk for 5 minutes. 5 minutes. Next week, they went to 10 minutes a day, 3 times. Next week, they went to 15 minutes. He did that until they were walking for 40 minutes. 40 minutes a day, 3 times a week. And that's it. And that's how much exercise they were doing. So it's not, it's not It's not marathon training. This was, this is a modest amount of exercise. I mean, it did get people's heart rate up, especially if you walk and talk. You work harder. So go with somebody. Women talk more than men, so. Well, there's data on this. It's true on average. So this is really interesting, and he's not the only one who's shown this. There have been kind of similar studies that have shown increase in brain volumes in other areas of the brain that are really critical for other kinds of mental functions, and have shown increases in some of the connections between different parts of the brain. Really, a remarkably strong effect.
Do you see any other compared studies about different kinds of exercise? When you mentioned walking, there would be weight bearing, weightlifting,
The question is about different kinds of exercise, and I don't know real well. The stuff I'm familiar with is all looked at aerobic exercise, but it's generally sort of low-level aerobic, not real high. Yeah.
But there have been studies about yoga and Tai Chi and that kind of thing too.
Yes. Right. So that's an interesting literature. The way I look at it is probably there's probably a pretty wide range of activities that would have the same kind of effect. I think, this was an easy one to look at. So I think what are we looking at? Fairly modest exercise, like 30 minutes. Doesn't have to be every day. And the key thing to me is you have to find something that people like. You just don't. People don't do what they don't like over time. But on the other hand, you can try to make it something that you like, and try to make it a part of your life. We were just saying, wide range of things. Okay. Diet. Probably even less popular than exercise. But there was a question earlier about the kinds of fats, and there was a question about alcohol. So here's where I'm going to come back to those. This article was published last month in New England Journal of Medicine. This is a really important article, I think. And it makes a point that I could spend a lot of time going through a lot of other articles on. So let me tell you about this study. What they did, this was sponsored by the Spanish government. It's not only the U.S. that's in this business. And what they did was follow about a large number of people, 7,500 people. And again, they took people between the age of 55 and 80, and they picked out people who were at high risk of heart disease, but who did not have heart disease. So they had to have multiple risk factors, the same ones I've been talking about, high blood pressure, diabetes, that kind of thing, but not have had a heart attack. And they enrolled them in this study. And what they wanted to do was to compare 3 diets. They wanted to compare 2 versions of the Mediterranean diet and a low-fat diet. Now, I'll tell you a little bit more about the Mediterranean diets, but basically one really emphasized olive oil, and the other one emphasized nuts, tree nuts and peanuts. And they wanted to compare this to low-fat diet. Turned out that the people that they put on the low-fat diet wouldn't follow. Probably people could have told them that, but they didn't. So what they ended up with was 2 versions of the Mediterranean diet versus usual, whatever you're going to eat kind of comparison. The other interesting thing about this study is the effects were actually so clear that they stopped the study part of the way through because they said the effects are so clear here, it's not ethical to just continue this in a random way. We've got to tell people about this. So here's what So in terms of the diet, this table is in the article. They describe it in more detail. But I've kind of put over on the side here what the diet emphasized was lots of olive oil, fruits, vegetables, nuts, and grains. So a lot of that pretty much every day. Modest amounts of fish and poultry, and wine. This was actually an important part of the diet. They actually said if you drink wine, you should drink at least a glass a day. I think it was, they weren't saying 4 glasses a day, but at least a glass a day of red wine. It's pretty rough, you're talking about 7,000 people, and they're all out doing whatever they do. So, but these, and then to limit red meat, dairy, stuff, and sweets. So that's basically the diet that they were looking at here. Hold on a minute. And here's the really, let's see, can you see these lines? What this is, so what you're looking at here, basically, over here is how many people had a heart attack or a stroke. So they had a heart attack or a stroke, or they died from a heart attack or a stroke. And the line just represents the number of people over time, okay? So the black line is the people who just were eating their regular diet. And you can see as the years go by, more and more people die or have heart attacks and stroke. This is the green line, yellow line, different versions of the Mediterranean diet. And you can see it starts at a lower rate and just continues that way. And the longer you get in there, the fewer people have it. It was really a very powerful effect. So the people on the Mediterranean diet were significantly less likely to have heart attack, stroke, or to die from either of those. So it was a really impressive, very impressive reduction of risk. It's on the order of 30%. Yes, it's like a 30% reduction. And so, these are with foods. There's no, these aren't side effects. These are just normal. These are just dietary things, and they have this kind of impact. So it was really, really a very impressive thing. And the Mediterranean diet was also something that people could work with. And they got pretty good compliance with it. They did give people food. There was a Spanish olive oil manufacturer who donated the olive oil. The California Walnut Commission donated the walnuts. People were able to, this was a diet that people could follow, and it really made a big difference in their health. And if I can, okay. So so I tried to show you early that if you think about what makes people demented, it gives them the kind of disabling loss of mental abilities. In most people, it's a combination of vascular things and Alzheimer's disease. We know a fair amount about how to reduce these vascular things. We actually know a lot about it. These are things that you can do, that patients can do, that people can do now to reduce risk. And I actually, so let's put it in this context. The federal government and the pharmaceutical industry are spending literally billions of dollars trying to develop drugs that stop this accumulation of amyloid. If that succeeds, it'll be very important. However, as I said earlier, people don't get Alzheimer's disease at a young age. People get Alzheimer's disease when they're old. And a lot of things happen to the brain along the way, vascular being the biggest one of them. It may turn out that among the various things that we can do to prevent dementia in old age is reducing vascular risk at a young age. Because these are things that happen over a lifetime. Doesn't mean that older is too late, but it does mean that what happens earlier, at a younger age, is really quite potent. And I really think it's a range of things, all of which reduce the risk. And so diet, exercise, mental activity, I didn't talk about that today, but there's also interesting evidence on this, and social engagement, staying involved with friends and family, also seems to make a difference. Okay. 15-second plug for our Alzheimer's Center. We do lots of research. We need lots of volunteers. We need support of all kinds. It's in this area. We have a website you can go to, and we have various community events. It's going to be handed out at the end. There's a flyer for one that's coming up on May 23rd. Guy who looks like me. It's not me. It's going to talk about art and dementia. It's a great talk. It's really interesting.
What's it called?
Portraits of Artists with Dementia. Bruce Miller, he's from UCSF. There's there'll be flyers in the back. And I just want to thank the people at our Alzheimer's Center, and I have time for questions. All right. Question there. Yeah.
Is that how they decide if someone has Alzheimer's? Because they were saying, at one time they had said,
Yeah. So the question is about the use of the PIB or PID-PET for diagnosis of Alzheimer's disease. So the acronym PIB is just it's a label. It actually stands for Pittsburgh Imaging Compound B. And when they were developing tracers, this was their compound B that they were trying. So and this name just stuck. But it's a tracer that they say sticks to the amyloid, and then you can use a PET scan to detect the levels of it and get these kind of images of the brain. Its use in diagnosis. It's a complicated question. There are the PIB compound is not going to be used in clinical practice for technical reasons, but there's very similar compounds that are going to be used, and one of them has been approved, and you can actually get these scans in the community. The use of it really has to be very carefully considered. If a person has dementia and and the scan is positive, it shows the amyloid, then it's extremely likely that they have Alzheimer's disease. I mean, that's clear. With the current treatments that we have, that knowledge is probably not worth a whole lot because it's not going to change your treatment at all. What people are interested in potentially is trying to diagnose this at an early point. Now, again, at this point, we don't have anything targeted specifically that's going to change that. And the risk is that there are a lot of people who are mentally normal, cognitively normal, who actually carry a fair amount of amyloid in their brain. 20-30% of old people. And whether or not they will ever develop Alzheimer's disease is not known at this point. So right now, it's not something that we use, or that I think is appropriate to use for sort of defining risk or predicting Alzheimer's disease. That picture may change.
Yeah, the reason why I wonder is because my dad definitely had Alzheimer's dementia.
Yeah.
24-hour care. My mom's, we're not sure if she's in the doing stage. So I thought that's something to know,
Well, I think to some extent the difficulty of diagnosing Alzheimer's disease has been kind of oversold. I mean, it is true that you can't know for certainty. On the other hand, that's true in a lot of medicine. You make a diagnosis and it's never perfect. And when you're talking with people who know what they're doing, or experienced, it's really a pretty accurate diagnosis. It's right on the order of 90% of the time, and to miss treatable stuff is very rare. So you can be quite certain with appropriate evaluation. I do think evaluation is quite important, but yeah. Back there.
When you mentioned the fact that some people carry the amyloid plaques and such in the brain that don't develop, is that part of the nun study that was done years ago with David
David Snowden.
You know, that the nuns that he studied, and that some of them even had the plaques in the brain, and the cognitive reserve, I think they call it.
Yeah. Right, many of you have seen publicity from the nun study talking, a very interesting study following a group of sisters for a long period of time. They had early life records on them and allowed them to do some very interesting work. There are a lot of, let me just pick up on one thing in your question. So as I said, the fact is a lot of people can have amyloid in their brain and they don't show the cognitive effects of it. And a very important question is why. And one of the ideas is this idea of cognitive reserve. And this is basically the idea that you don't need all of your brain capacity to get the work done. So you sort of have more than you need. And that you can lose some capacity and compensate for it. And there's essentially a lot of evidence for this, a whole range of things from education to intellectually demanding work to recreational activities that are cognitively stimulating, maybe also creative and artistic kinds of recreational activities, all may protect, protect the brain from the effects of the pathology that accumulate as we get older. Well, yeah, the question is, do they protect? Yes, I think they do, but it's not just artists and musicians. It's a whole range of things. A lot of mental activity seems to protect. Let's see, question there.
You mentioned about executive exercise and diet was decreasing vascular. Now, what if an individual will say, okay, well, I'll exercise, but I want to have all my fats and milkshakes and how does that compare? If you say, well, I won't fulfill the diet, but I'll just take Lipitor or something.
Yeah.
How is that?
Well, okay. Diet operates through probably multiple pathways. And Lipitor or statins interrupt one very specific pathway. So they interrupt the pathway by which the low density cholesterol gets created into the body. So the way I think of it is diet affects your body in many ways. So if the diet is bad, it's probably bad in a bunch of ways. So it's hitting a lot of different systems. So if you want to stop one, that's fine, but you still have all these others, and it doesn't compensate. And no drug yet, statins included, is free of side effects. So it's not, I'd say it's not the best approach. Question here.
I want to know, is it
Hereditary. Alzheimer's disease. So Alzheimer's disease has a hereditary component. Here's what I mean. I think the best way to think about it is that when it comes to genetics, there are actually kind of two different forms of Alzheimer's disease. There are a number of genetic mutations that lead to Alzheimer's disease in a very strong way. They're like other genetic disorders where the families that have each of the children have a 50-50 chance of getting Alzheimer's disease. So that's a very powerful effect. Those kind of mutations are very rare. They explain probably under 5% of the cases, and most of those are families where people get the disease when they're very young. By that I mean in their 40s, in their 50s, maybe a bit older, but but these are the younger people. The average age when a person gets Alzheimer's disease is actually like 75, and most cases are people who develop it later in life. In late life, there are genetic influences, but there's a lot of them, and they're weak. So it's the sort of thing, you can think of it as like, you know, if diabetes runs in your family, yeah, your risk is probably higher. It raises the risk, but it's risk. It's not certainty at all. And in most of these cases, the chances of a child escaping the disease of the parents are higher than getting it. With Alzheimer's disease? With Alzheimer's disease or with? Well, having a big family, so she's saying that her brother who got it in his mid-70s and then daughter who got it much younger. You know, having a big family is actually helpful in understanding that because these really powerful mutations move through families, and you see it. You see it if you know the family history. The families with these strong genetic mutations, they know it. A couple of members here and there is unfortunately really, really common. So I don't know if I can define it better. But, question from somebody who hasn't. Yes.
You were talking about statins earlier, and I wondered if statins cause any memory issues or cognitive decline.
There are, the question about statins and cognitive decline. There have been some case reports. Seems to be a relatively rare side effect, but not unknown. Cholesterol is, you need a certain amount of cholesterol. The statins are not so potent that they completely block it. But there do seem to be as I say, very uncommon, a small number of people where you do see this side effect. Great majority of people, that's not the kind of side effect you get into trouble on statins.
How about somebody who tends to be a worry and tends not to be able to handle stress? How does that happen?
Yeah, a question about being a worry ward and stress. How does that happen? So that's a question I don't like because the answer is doesn't seem to be good for you, which makes you worry more. There's a whole line of evidence that suggests that some of the effects of chronic stress, chronic worry, can have harmful effects on the hippocampus, this brain structure that I talked about as being so important. Remember? Yeah. And there's also evidence that people who have a more pessimistic outlook and who are have a harder time dealing with stress overall may be at somewhat elevated risk for dementia and late life. So they say, I don't like, that's not what people who are kind of worry wards need to hear. But again, in terms of things that can
Or a couple of factors.
You don't want to be chronically stressed for a lot of reasons. It's also related to a lot of negative health outcomes. It is one of the other benefits of exercise, and many people find it helpful in managing mood, stress, and anxiety. So it's another reason to consider that. Right here.
I'm not that familiar with all the diagnostic tests you do. Has there been new tests for the last 5 or 6 years? I go up to healthcare, so there's that question. They think it's just 1 or 2 tests, and I know it's not bad for your test. when they develop new symptoms?
Your question about advances in diagnosing Alzheimer's disease. Alzheimer's disease is, so let me put it this way. What is the kind of evaluation of personality? Because I think that's the way to look at it. I think it is best to get what I would characterize as a comprehensive evaluation. So you really, a doctor should look at the overall health of the person. Again, these are diseases that happen in older people where there's both vulnerability and a lot of things happen. So you really want somebody who will look at the whole picture. You want somebody who's knowledgeable and specialized to a degree so that they know the various underlying conditions that can cause these things. The workup itself is, in the medical world, it's moderate. It's not tremendously complicated. They're routine blood tests, simple things, inexpensive things that are looking for treatable disorders. Neurologic exam is usually helpful. Brain scan is often helpful. The kind of, looking for the amyloid plaque, I think, is not usually indicated. You don't usually need genetic tests. You can find the markers of Alzheimer's disease in the spinal fluid. Again, I don't think it's usually indicated, but it's complicated in the younger people. I think sometimes that can be done. How about in the pink? Next. You haven't had, but let me, yeah.
I just heard of a recent test regarding aspirin and dementia, like they're taking a baby aspirin a day, it affects Alzheimer's.
The question was about low-dose aspirin and Alzheimer's disease. Actually, I don't know. I didn't see that. A lot of people take aspirin to protect against vascular consequences. So, especially people who have had an event. Yeah. So, I would not be surprised if it was beneficial in that way, but I actually don't specifically know that study that you're talking about. Now, where was it?
I would like to comment on the increasing incidence on earlier onset, because you keep saying it's an older person's disease, 75, with, 15, 20 years before that. What about those folks that are being diagnosed in their middle 50s now?
There's just more of them around. It's sort of the baby boom wave is just here, and there's just a lot of people in that age range. I don't know of any evidence that prevalence has increased, so the rates of it are about the same, but there's just a lot of people at risk. And that's one of the really scary things when you look ahead 10 to 20 years, and all these people are going to get up in the age where Alzheimer's disease is really common. And we need to do something to head this off. There's a lot of people.
Is a cure coming up maybe 20 years? Do you think there's a cure on the horizon?
Cure. Well, hold on. Let me. Yes, you. No, the woman behind you, please.
I have a question. I work at a senior independent living center, and we have a woman, she's 106 months, and she's very active, and she told me that she's telling everyone that she's taking a vitamin called choline. She's been taking it for over 50 years, and she believes that's helping her cognitively, but she's she's doing well.
Yeah. Yeah, so the question is about a woman who's going to turn 100, and she's taking choline.
And she is 106 months.
Yeah.
She's been taking this for over 50 years.
Yeah, so she recommends this drug. Okay, a couple things I'd say about this. People who are really old are different. They are. There is something. They are resistant to a lot of things, and you hear those things. But my grandmother died at 94, and she smoked up until a year before she died. And she probably only gave it up because she got really sick, not with lung disease, right? I just say people who get that old really are able to resist a lot of illnesses, I think in a somewhat special way. And so I don't know what to make of their experience.